So Ayushman Bharat Digital Mission. Next slide, please. So how do we all carry our health records? Most of the people, we usually carry our health records in a file system. We have it physically with us. We have huge files that we carry around everywhere. So what is the problem with these file systems? They can get easily damaged, they can be destroyed, we misplace them, and most of the time people tend to forget it when they come to the doctor's visit. So ABDM tries to address this specific issue. It tries to create a digital health information platform and make us go towards a paperless ecosystem. Next slide. So are we not digitalized when it comes to health? Of course we are. We have our very own portals when it comes to health information. We make RCH entries, we make TAI registry. Every hospital has its own MIS systems. But what is the problem with it? There is no interoperability. There is no exchange of data that is happening between these platforms. So what ABDM actually does is, it creates an ecosystem that is interoperable. It enables data exchange between various digital platforms that already exists. So when we use the word data, what obviously comes to people's mind is that our data is being captured. It might be misused. Somebody is trying to steal all our data. That sort of concerns obviously comes to everyone's mind. What ABDM does not do is, it does not have any sort of central repository. Every data that is being created resides with the creator itself. Next slide. So the visions of ABDM are, it is inclusive, it is accessible and affordable, it is safe and secure, and it is timely. Next slide. So why ABDM? For a citizen, ABDM helps to access all his medical records at his fingertip, and he can even consult a doctor remotely through an ABDM platform. And for a health professional or a health facility, it enables the facility to access health records with the consent of the patient. And for policymakers, that is where we come in, ABDM gives us a source of trustworthy data upon which we can make our policies. Next slide. So this is the whole ABDM ecosystem. On one hand, we have health information providers, and on the other hand, we have health information users. Basically, both are the same. All our citizens and private digital health services and government digital health services, through a connecting platform, we facilitate exchange of data. And that is where the 4 registries come in: ABA, HPR, HFR and drug registry. So these are the 4 registries that we create in ABDM ecosystem. ABA is for the citizen. It is a 14-digit unique number for every citizen. And HPR, Health Professional Registry, is for the health professional providers. Basically, they are doctors, nurses, paramedical staffs, etc. And Health Facility Registry is for the facility. They range from big, huge medical colleges to even a small clinic, even pharmacies and laboratories. And the final one is Drug Registry. It is for all the drugs that enables e-prescription. So this is ABA. ABA is a 14-digit unique identification. So why ABA? ABA tries to simplify things. It is a unique number to each citizen. So instead of having a different identification number in every hospital, the citizen can have one registration number through which he can access all digital health facilities, and that is ABA. So when a citizen registers ABA and he uses a PHR app, and through the PHR app he can create his health records and keep the health records in his health locker, and based on his consent he can share the records to the facilities, and that is how a citizen can become a digital citizen. So this is the second one is health professional registry. As I have already told, this is for healthcare providers, doctors. All modalities of doctors can get registered under HPR, and healthcare professionals and allied healthcare professionals also. So what are the other key benefits of HPR? Basically, it is a trust and verifiable entity. Doctors have already their own registration number, but this also provides a trustworthy national level identification. So basically, with the HPR, a doctor can create health records at his facility, and using a ABDM compliant HMIS, and he can prescribe digitally, and that is how a doctor can create a digital health record at his facility. So next comes health facility registry. Similarly, as HPR, this is for the facility itself, and this is also a national verification building trust. So the same workflow is for the health facility registries also. So these are all the various personal health records app. The ABA and Arogya Setu are the government apps, and we have many private partners too, such as Briefcase, Paytm, Bajaj Health. Using the personal health record app, one can create an ABA address, he can link his health records, he can view his health records, he can book his appointments through scan and share for OPD registration, he can manage his health records that are shareable, and he can even update his profile. So next is end-to-end ABDM adoption, that will be spoken by Dr. Jothiban. Thank you.
Good afternoon all. Respected DPH sir and participants of the workshop. I thank you all for giving me this opportunity. So why ABDM? So why is ABDM? So why do we need to digitalize the health records? So in most of the cases, how long do we preserve our health records? If you ask this question, you all know the answer. When the treatment gets over, the records are over. It's finished. So what is the disadvantage? So okay, let it be. The treatment is over. The records, let it go to waste. What is the problem? So you all may think. So there are, we as a doctors, we all know there are a lot of cases where the previous records are very important, especially in surgical cases, oncology cases, we all know. So these records are very valuable, and the next doctor who is going to treat the patient, he can take most of these decisions based on what treatment was given previously. So these records are very invaluable. So these records need to be preserved. So Government of India has taken this initiative to preserve all these records. Not only preserve those records, the public should access their own records. The public should know what treatment is given and what all treatment he is going to get. So this is how the program is designed. It's basically a citizen-centric program. So my colleague has explained very well about all these pillars of the program, all the registries which are getting created. So ultimately, what is the purpose? The patient, he has to enter into the hospital, all his records, all the prescriptions, all the lab reports, whatever is generated in the hospital, it has to be digital. So when he comes out of the hospital, the patient should be able to see all his records, whatever is created. The happiness, I'm seriously telling that the happiness which the patient gets on seeing his records, all these prescriptions, lab reports, everything, it's invaluable. So ultimate aim is when the patient goes out of the hospital, he should be able to see all his records in his own phone itself without any difficulty. So we will quickly go through a few slides. So the Government of India actually has created few model facilities, actually around 134 model facilities, out of which 29 are AIIMS and central government facilities and 90 are state government facilities. and 15 private facilities are also included. As we all know, the private participation in this program is also very important because there is a data which says that around more than 50% of health data flows through the private ecosystem. So the private data is very, very important. So without capturing the private ecosystem, the system is of not much value because most of, as I said, 50% of the data flows through the private ecosystem. If we miss out these data, it will be proved to be costly. So we are also trying to capture data from the private facilities also. We have all these 15 private facilities which are model facilities which is implementing the program. They are doing end-to-end ABDM adoption. So we will quickly go through what is end-to-end ABDM adoption. As I said earlier, when the patient walks into the hospital, his registration should be done in a digital way. The OP slip should be created in a digital way. Next is creation of health record. All his health record should be created in a digital way. Next, digital payments. If suppose any payment has to be made, instead of waiting in the queue, the patient should be able to scan a QR code and make the payment. Then access to the electronic health record. So that is our ultimate goal. The patient should be able to see all his electronic health records. So this is what is expected in the patient journey. So what is expected from the hospital? The facility should have scan and share. I will explain about the scan and share in a short time. So scan and share is basically a OP registration process. Then next comes the health record and lab report and whatever records linking. Then is the scan and pay. Then IPD registration and end-to-end process completion. So not only it is useful in OP procedures, it is very useful in IP monitoring also. So basically if the program has to run in a very seamless manner, HMIS is the basic component. HMIS is the backbone. So without HMIS, this program is useless. So as you all know, we have very few government facilities with current running HMIS, which is being implemented by CDAC HMIS, as you all know. So there are two model facilities which are using this HMIS. One is Tirunelveli Medical College Hospital and other is the Keelpark Government Medical College Hospital. These two hospitals are end-to-end ABDM compliant. I have few pictures of these hospitals with the capability of end-to-end ABDM compliant. I will come to that in a short time. In the private ecosystem, we are using a lot of methods. We have a few team of around 10 members in TNHSP who are going hospital to hospital and trying to make the hospital ABDM compliant. So there are few materials which are basically required so that the facility can be declared ABDM end-to-end compliant. So first is the HMI system along with functional PC, laptop, internet facilities, TV monitors, etc., the required hardware. Then the module for ABDM enabled HMIs with lab and pharmacy module which has to be there. Then we need to create lot of the ABA ID for the patient. Then only the records will get along with the ABA ID. So the creation of ABA ID is very mandatory. So scan and share is an EC registration process which we will see. Then rigorous IEC material. All these things has to be there. Then only the hospital can be declared ABDM compliant. So the photo you can see, this is not in our state, this is in North India. So in the first photo you can see there is a lot of queue waiting there. The basic reason which was identified for the queue was, one is the receptionist was typing the demographic details. So what you will do is, what is your name, what is your phone number, tell me your father's name or address, everything he has to type. That is one problem. And the next problem is like whether it is a verified data. No. The patient, I go to the hospital, I don't want to disclose my identity, I can tell my name, I can bias anything. So these kind of problems are there. So what we have achieved with the scan and share is, there will be a QR code which will be displayed in the hospital OP desk. So you can see this is the QR code which is placed in Keel Park Medical College. So the patient has to walk into the OPD, he just have to scan the QR code. So by scanning the QR code, two things will happen. One, all his Aadhaar verified data will transfer directly to the OPD counter. So that is number one. So the data is verified and authenticated. So next thing, there will be a creation of token number. So for example, if I am the patient walking into the queue, by scanning this QR code, I will get my token number. I don't need to wait in the queue for a long time. I can go sit anywhere in the hospital. So whenever they call my token number, I can approach the registration desk and I can get myself registered and get a OP slip. So this all process these photos has been taken from Keel Park Medical College only. So this is how the token number gets generated for the patient. So when the token number 29 is called, the patient has to approach the OPD desk and he can get himself registered. So this is a screen of a doctor, treating doctor who is going to see the patient. So he has two options. So if he is a new patient, he can treat directly, or if he wants to access the patient's previous records. So what he has to do is he has to raise a consent. So these records cannot be accessed directly. So these consents are granted in two ways. So one is through the PHR app. So through the ABA app, the consent can be raised and the patient can give consent for sharing his health records. This is one method. The next method is OTP. He can raise a OTP if the patient don't have an Android phone or something. The patient can share the OTP so that the doctor can see his health records. So this is how the doctor views the previous health records. So next, if the doctor wants to refer the patient to the lab, so inside the system itself, the QR code will be generated, and out of this QR code, stickers can be printed. So by using the stickers, the samples are collected in the lab. The stickers will be placed on the tubes, it will be processed, and the reports are purely QR code based. So there is no chance of like mismatch of reports or something like that, because everything is QR code based. So once the lab reports are ready, the doctor can see the lab report in his own screen. He can take the clinical decisions and he can give a prescription to the patient. So everything is happening digitally. There is no paperwork in between. So as far as the patient, finally all his records he can access through the any PHR app. So through ABA app itself, if the patient log into his account, he can be able to visualize what all records are generated right from entry into the hospital till the patient comes out of the hospital. Everything is digitally recorded and everything is accessible to the patient. So ultimately, the patient can view all of his health records in one place. It is arranged in a chronological order. So, for example, I take a treatment at Madras Medical College today. So those records will be recorded. So after 1 week, I go to Stanley. All these records can be viewed by the patient and the treating doctor based on consent in one place itself. So this is how the system works. So I thank you all for giving me this opportunity to showcase this program. I hope everybody understood the concept and it will be implemented in future. Thank you so much.
So we thank both Dr. Jothiban and Dr. Sankameswaran. Please be seated. Thank you for your presentation. A very important area for discussion actually, but we are actually touching upon the lunchtime now. The point is, there is a great challenge at national and state level for fixing up a unique health ID. If the states are all connected together based on a unique health ID, then half the problem is solved. So in that way, you have your ABA-ID, the ABDM generation, which is supposed to show, which is showcased as a model. And of course, there are challenges. And state governments also have their own unique ID. They are also trying to bring up. So I think it is an area where we are struggling to make it happen. But some model, both of you explain very well, some working models, especially in Tirunelveli Medical College and Kilpak Medical College. Dr. Sendil, our joint director, had lot of exposure and experience. He should have been the moderator for this. I actually thought after I came over, you would have been also very good to support and complement to the discussion going on. The forum is open for the audience to tell your views, or like say anything which will bring more meaning to the table. Kindly introduce yourselves.
Hi, my name is Devesh Verma. I work for Ola Foundation. I have a question for both of you. Am I audible?
Yeah. You keep the mic closer, sir.
Sure. Thank you. So you both spoke about interoperability, you spoke about facilities. The question is that purely from a public health information continuum perspective, how do you see the way ABHA was visualized right from when the digital blueprint came out, and I was lucky enough to be part of those blueprint discussions as well. What I want to understand is that if I look at per facility ABHA implementation or ABDM implementation, how do you solve the interoperability problems within disparate systems? Is it something that you would create an interop for, let's say SNOMED or ICD or LOINC, or they will have to work on? So what is the approach to bring or converge everyone to adopt a system like this? Right now, one facility, longitudinal, does not solve the true sense of ABHA.
Sir, I hope I have got your question right. So you are asking how two institutions talk to the system. I hope this is what you are asking.
It could be two or more, because that's the whole idea of converging a longitudinal record.
So basically, this HMIS has to be ABDM compliant, sir. So for example, I have XYZ hospital, there is another hospital. My hospital has to be ABDM compliant. There are 3 milestones the hospital has to cross: M1, M2 and M3. So M1 is basically creation of ABA ID. M2 is creation of health records within the institution, and M3 is interoperability, where the patient can access his records anywhere and any other hospital can access the record. So for this, the integration team is there at the national level. So there is a sandbox. We have to register in the sandbox. We have to register our HMIS, and through the sandbox registration, the NHA team, the National Health Authority, Government of India team will work along with us and make the HMIS ABDM compliant. There are few HMIS which are already ABDM compliant. The HMIS which I showcased to you, the CDAC HMIS, which is ABDM M3 compliant. Also, there are around 57 private HMIS players which are ABDM compliant, which are available in the NHA website. So those HMIS are basically plug and play. So any hospital can adopt those HMIS and they can start using. Only thing they will be charged a nominal amount for using the HMIS. So if I already have an HMIS and I don't want to change the HMIS to another one, then any HMIS can be integrated using the method which I told you in the beginning. Like it has to cross through 3 milestones, M1, M2 and M3. It will take some time. It will take around 50 to 60 days at least. It will take some time, but any HMIS can be made ABDM compliant. The integration network is there. Integration can be done in a seamless manner.
So that I agree. Systems exist, but then we are still not solving the public primary healthcare problem. How can I expect?
Can you change the mic, because we are not able to hear well? Either sir is not speaking close, or
I am putting it.
yeah, change the mic.
Can you hear?
Yeah.
So I'm saying that's well established. That's what ABDM provides as framework. But the question is more nuanced. If I look at a sub-center and people walking up to sub-center, there is a lot of encounter that happens at the doorstep. So that information continuum from the doorstep to sub-center to a PHC to a CHC, then to a district hospital needs to happen. Now the interop does not exist between these facilities. There is a lot of tertiary ABDM with ECA care and PayTM, but that does not solve my citizen's problem who is at a village level. They cannot carry their medical record. So how is ABDM now thinking of, from a state-based perspective, to solve for this? E-Sushrut or Mera Aspatal or E-Aspatal are systems available, but they are a DH or a CHC available facilities. But what happens at a ground level? Anmol is still not compliant with ABDM, right? So how do we solve that?
Sir, basically, what is required is a HMIS, sir. So, right now, when you are talking about the primary care, in the government side, CDAC is implementing the HMIS. So, at the primary level itself, the CDAC HMIS will work, even in mobile phones. Basically, the record has to pass through the HMIS system to get into the ABDM record. So the HMIS will solve all the problems. The HMIS has to be fine-tuned in such a way that the record has to be captured and the HMIS should be ABDM compliant. That will solve the problem, sir.
I think what sir is trying to explain, Jothiban, is patient-centric data. So patient-centric data is more viable in the hospital setting. Your second year tertiary care, you got a individual patient-centric data. With the PHC and sub-center, we have more of a HMIS data. Now, if you want to connect all the thing, it should be a patient-centric data, which ideally should be generated from bottom level, sub-center and PHC. That's what he's trying to say, which is not actually in place. So, what do you like to tell about it? That's the question.
So just to add on that, as sir already said, HMIS is the backbone of ABDM, sir. Without HMIS, ABDM cannot function, because without HMIS, we will not be able to capture the health data. When it comes to a primary health center or a clinic setup in a rural area, one thing that is recently being developed is E-Sushrut Lite. They are launching a light version of E-Sushrut, which is very easy and doesn't require much of connectivity or technical knowledge to be operated. So that is going to be rolled out soon, and a small clinic or even a primary health center with the support of government can adopt E-Sushrut Lite and can start gathering patient-centric data, sir. But without HMIS, there is no capturing of data that can happen, sir. So HMIS has to penetrate till the grassroots level.
Sure, thank you.
Professor Dr. Raghunandan wants to say something.
Just only one thing, sir. Regarding the privacy of the individual, is it at stake? Because as a patient, as an individual, can he say my data should not be documented? Is that right, or it's compulsory, it is going there, number one? What is the quality of the data? For example, some sensitive issues like HIV status and other things. Similarly, whether it is it's a must in a private sector also.
Sir, it is not at all mandatory, sir. A patient can or cannot generate his own health records. Because when it comes to a patient generating a health record, only he is going to do that. And if he wants to share that particular data to a hospital, it is only consent based. The hospital will request the patient's data, and only if he consents, it will be provided to the hospital.
So it cannot be shared without the patient consent?
Without the patient's consent, it will not be shared, sir. The entire health records capturing and sharing is compliant with the DPDP Act.
Sir, also the data cannot be, is not being stored in any government server, sir. The data is kept maintained in the hospital only. Only thing the government is providing a gateway like UPI. So the transfer of data from one hospital to another hospital. So this is what the government is doing. The government is not capturing any records from the system itself. Thank you.
Okay, I think there are no more questions. I think we can wind up the session, and we congratulate both the speakers for really bringing an important topic and we should go a long way in this also, the times to come.
I need to add one thing, sir. We do have an active stall in the entrance. Doctors can get their HPR registry done. It will be helpful because this is going to be the future. Thank you, sir.
Thank you, dear sirs, for clearing all the doubts from the grassroots level. DPH Icon 2025 invites a well-informed, conversant, genial, affable, biovent, and pragmatic Joint Director, Maternal Health and Child Health Services, Dr. J. Nirmalsan sir, onto the dais to honor the speakers. Thank you, sir.